Good morning, everybody. Dr. Gabriele Jasper MD, interventional pain doc with Jeremy Vickers, the greatest social media guy in the world.
Yeah.
All right. So he set this nice podcast for everybody to understand what we do in interventional pain. And like I always say, interventional pain is not just pain management. We have so many people that see pain management. They come into my office and they want narcotics, drugs, but they have a rude awakening when they come to my office. They're not going to get that. But at the same token, I see these same people that I can get rid of their pain, and it's just so difficult for some of them to understand that I can get rid of their pain.
Yeah. Yeah.
You know, they have pain generators which I could find and get rid of, but some of them say, "Okay, let's do it." You know, some of them are sincere, some of them are not, and they're hoping that eventually I'm going to give them pain medication.
That's how it was with you. I was on pain meds, and I went from pain management doctor, in quotes, pain management
Yeah,
doctor, and from pain management doctor, and it was all the same thing. Okay, and then we're going to give you the meds coming, and they wear off and it's like they don't even work.
yeah, that's not going to happen in my office.
Yeah.
Like I said, we're going to find a pain generator. That's what we do. That's my definition of interventional pain.
Mm.
We find out what is actually causing you to have the pain, and we get rid of it.
Yeah.
And there's so many new different techniques that are coming out. In fact, there's a new technique that came out recently that we haven't even talked about. You know, it's been out for a while, but it's new to my practice. And what it is, it's called Via Disc. And what we do is we kind of rejuvenate. You know, it's my own words. You know, the spine is made up of, the disc is made up of an annulus, which comes on the outside. That means ring, and then on the inside is this nucleus. You can see there's a little crack in the annulus, and some of the nucleus leaks out, and that causes a herniated disc right here, which puts pressure on the nerves. You push this down a little bit. And by putting pressure on the nerves, that causes a sciatica type pain.
Yeah.
But if we can get somebody that has degenerative disc disease without a crack and a big herniation, basically a disc that is contained, which is degenerative. There's a facility down in Florida, a multi-million-dollar facility, where what they do is the people who have donated their bodies to science. Their age is anywhere from 15 years old to 55 years old.
Right.
They donate their bodies, and every part of their body is actually utilized for science. And this particular facility, what they do is they find these young people and they look at the spine, and they get a perfect spine with a perfect nucleus. And what they can do is they can take out this nucleus and they process it. And they process it in a powdered form, and then it comes to our facility, and people who need like rejuvenation or a nucleus, we could actually inject it directly in where the old degenerative nucleus was, or whatever's left of it, and we can replenish it and give you more. It's not a disc replacement. A lot of people ask me for disc replacement, but what it does is it reconstitutes this nucleus.
Well, fills it up, or
Well, what it
refills
does is it's in a powdered form, and we reinstill it with normal saline, so it becomes moist, and we put it in there, and it stays in this area. You got to make sure there's no leaks in it,
Right.
in the disc, and it absorbs its own fluid through the body from osmosis, and it increases the volume of it, and then the shock absorbing effect comes back. So this is the way I interpret it on how it works, and the criteria is somebody who has pain when they lay down, try to lift their legs up. A lot of times you have pain when you sit down, or pain when you lean forward, especially people who are shaving or putting on makeup. That's where you have the most pain, and it's discogenic pain. Some of these people have pain when they sneeze, when they cough, and the procedure is a very quick, safe procedure. No general anesthesia. In fact, some people can do it without anesthesia at all. especially people at a high risk for anesthesia. So it's showing very, very promising results.
Here we go. We got Rob Viatan, Vitan, and he says, had my epidural 4 weeks ago and been pain-free since. Thanks, Doc.
Oh, you're welcome, Rob.
Yeah.
I'm glad I could help you. That's fantastic. I like this. He's never listened to us before.
No, I haven't seen him up here ever, right?
Yeah, thanks for giving us that little feedback there. See, people are very skeptical about what we do. Why? Number one, they don't want any injections. They're afraid of the injections.
Yeah.
Number two, they figure anybody advertises can't be that good. But if you look in our archives of in our website,
Yeah,
and also YouTube videos with testimonials, you'll see some great testimonies about the different procedures that we do.
that was something that we did together, just through that the advertising, like when we first started really doing it on TV and on radio. Doctors, a physician, a surgeon, advertising on television. It wasn't
Well, I remember
really
the old days. My father, I said, "Why don't you advertise?" He said, "It's unethical." But
Yeah.
today, the reason why we have to advertise today is because you have the hospitals now advertising, and they most of the doctors are private physicians, if there's any left. I'm one of the last of the Mohicans left as far as a private practice, and it's going in the direction of hospitals with hospitalists that work for the hospital. They work for a system, and there's quite a few of them. And when they work for them, they're working for somebody, so they're not really working for themselves. So there's a problem when it comes to that. That becomes a problem. Hey, we got a new guest today. We're going to set him up here. Have him sit down over here. But anyway, going back to finish this topic is we talk about doctors that work for hospitals.
Right.
I had a patient come into my office last week that had a lot of pain in their back, and they went to the hospital for severe pain. They did a chest X-ray. They did an X-ray of the spine, and they did an MRI. No, they didn't do an MRI. They did a CAT scan of the spine, and they gave him some pain medication. They sent them home. I got the same. Where did he do? They did it. They did an MRI. Right. They did an MRI, and they sent him home, and that was the end of it. And he was in a lot of pain. It was my patient years ago. Says, "Let me call Dr. Jasper with my back pain." So he called me up, and he made an appointment. He came in, and I looked at his MRI. And very simple. You don't even have to know how to read MRIs half the time, because I read my own MRIs. I'm pretty much a master of reading the MRI of the spine. However, I could dabble a little bit. I always like to look around a little bit, and I saw these masses in like the bottom part of the lung. I'm like, and I asked the nurse, "Did you read it?" She goes, "Yeah." And they describe masses in the lung, and I didn't even see the MRI of the thoracic. And they say that there's a suspicion of tumors that have metastatic tumors from the lung, right? And then they said they saw in the mediastinum, which is in the middle between the lungs, they see lymph nodes and possible metastatic. I mean, you don't have to be a rocket science. You read the MRI report. I mean, and I hate to talk bad about any doctors, but these are hospitalists that should have followed up on this guy. But it's not that it was that long ago. It was only about 2 weeks ago, but nobody called him. Nobody said anything. So I sent him to an oncologist, and we don't know the results yet. But here we go. We got Dr. Radcliffe here.
Yeah.
Orthopedic spine surgeon.
Try this one right here.
All right. Hi. Thank you.
Thanks
for including me. Thank you.
Yeah, Dr. Radcliffe's getting very, very busy, and he does a great job. I know him very personally now on 2 levels, personally and also at the professional level. And he is unbelievable as far as his surgical technique, the fact that he's conservative and he's not going to do unnecessary surgeries. There's a lot of guys out there that do that, but he's an honest guy. He's the most honest surgeon that I've met so far. And he's got a few things he wanted to bring up today. And you got the floor there, Dr. Ratcliffe.
Yeah, thank you very much for having me. It's great to be back. Yeah, a couple things.
Yeah, I haven't seen you in a bit.
Yeah, but it's been a while.
Yeah.
But you know,
I've been hearing good things though. I really have.
Thank you.
Yeah.
Yeah, it's been really good. So I'm so excited about the center and about the way that we've been able to offer excellent care at the center, and do some really amazing things. We did a case. Dr. Jasper and I did a case just the other day, and we didn't even have to put the person under general anesthesia. She had concerns about being under anesthesia and about recovering from anesthesia, which is totally understandable. And look, anesthesia is safe, but obviously if you can avoid that, avoid the nausea and being groggy, it's better. And so we've been able to do some cases, some spine surgeries, without having to put people under general anesthesia with just really good other medicines. It's challenging and it requires, a lot of collaboration between Dr. Jasper and another anesthesiologist, Dr. Wynn, and myself. But we're able to do really impressive surgery in some cases with even minimal morbidity. I mean, can you imagine having a spine surgery, not even having to go under anesthesia? The person can almost talk to you during the surgery, which adds to the safety. And I'm really proud to be able to offer that, and really excited. It's not for every surgery and every patient, for sure, but in the right situation, I think it's really safe. And I think intuitively, you're kind of afraid of like, oh man, I don't want to be awake during my surgery. But you're not like, it's not like we're asking you to hold instruments or hold retractors or something like that.
No,
You're
and-
not screaming.
I've been in the position where I've been awake during surgery, and
During spine surgery.
Yeah.
Actually, you actually had a surgery that you couldn't have anesthesia for some
Yeah.
reason.
no, it was real quick. That's why. And for
Oh, what happened? We had no anesthesiologist.
Oh,
And I'm an anesthesiologist, but I was a surgeon.
yeah.
So, and he developed, I think, foot drop.
Yeah.
And I said, listen, we can wait for a surgeon for next week, but that's a higher chance that your foot drop is not going away.
Yeah.
So I said, we could do it. I think it was a Tuesday. It was no anesthesiologist. I said, we'll do it Tuesday. I used a lot of local anesthetic, and we did it, and it was relatively not uncomfortable.
Yeah.
A little bit here with the needles and the local anesthetic, but sure enough, we did the surgery, and the next day he had no more foot drop.
It's
And
wonderful.
it's worth the effort. And as
Yeah.
far as you say with anesthesia, if you have a good anesthesiologist, that's not lazy. Let's say, I hate to,
Yeah.
me, I'm always talking about stuff like that, but you got to have a good anesthesiologist that's ambitious, that has been trained well.
Yep.
And believe me, just like surgery, just like anything else, it's how you've been trained and your motivation.
Yep.
I mean, it's not easy to do that. You have to really concentrate on doing anesthesia. The way Dr. Ratcliffe is talking about it, and you have to have special technique, and you got to be experienced and trained well, and it goes very smooth. And there's different levels of consciousness depending on the type of surgery. If it's a very big surgery, you can still do it with out general anesthesia, and a patient completely unaware of what's happening and breathing on their own.
Yep.
And that's anesthesia without general. That's without general anesthesia. That's called local with sedation, but consciously the patient is not conscious.
Yeah.
But if need be, if we need to test nerves or something like that, we could lighten them up in a very short period of time, and we could test it. And the type of medicine that we use medicine for pain, we use medicine for the consciousness, and we use medicine for anxiety and amnesia.
Yeah.
Right. So, I mean, I've had patients that were totally awake, totally communicating with certain types of surgery where it's not very painful, but especially when you use the right local anesthetic. And we had complete conversations throughout the whole case. And then we're done, and they say, okay, when are we going to start the case? It's amazing. That's one of the things I love about anesthesia. You can really manipulate everything.
You asked if I wanted to watch, and you repositioned the monitor, and let me watch. Just look, and you're like pointing things out. Look, Jared, see this right here?
Yeah.
Yeah.
like in real time as you were doing it. You know.
Yeah.
So I think that's important for patients to realize. Getting back to what y'all were talking about when I first got in here,
Yeah.
just about the hospital. The general anesthesia is to some extent the easy button, and it really is much more challenging and much more sort of labor intensive for the anesthesiologist or the anesthesia provider to not totally put you under general anesthesia and to kind of work with you and watch you and just keep you breathing and awake on your own. But the benefit is really there if it, it's particularly in certain cases, in terms of recovery, in terms of just bouncing back quickly. So it certainly is something. And again, I think that's the benefit of a ambulatory facility such as the Jasper ambulatory surgery center, that we want people to not take a long time to recover, to be able to go home and be comfortable and not to have a rough night that night. It's just different when someone's, kind of in the hospital, and there's just so many other things going on in the hospital, in terms of other surgeries going on, and people coming in and going out and taking call and so forth, that I think you get much more nuanced, individualized care in the surgery center, in the facility.
And it's as you alluding to, it's the care, the continuous of care, continuity of care,
Continuity of
where
care, yeah.
you could be in the hospital for an hour-long case and have 4 anesthesiologists come in.
Absolutely.
I mean, I've experienced it. I've worked in the
Yeah.
hospital where they take breaks, they go for lunch, which is, people have to do this, but that would never happen in a good surgery center,
Never.
because usually you got one anesthesiologist taking care of all the patients, and they are there. Maybe they'll take a lunch break, but everybody takes the lunch break at that
Yeah.
point.
Right.
And the surgery center runs the way the way we want it to run. It's our place, and it's catering to the patients. It's satisfaction for the patients and safety for the patients.
Safety for the
So,
patients. Yeah.
people ask, "Oh, do you have your team at the hospital?" And the answer is yes and no. Particularly for the person in like the nurses who are kind of handing instruments and working with me, and if I'm doing an instrumented case, the representative from the various companies, I know exactly who they will be. But the truth is that there's also a lot of variability and flux in the hospitals, because of staffing issues and just everything else, vacations, call, and other stuff. So the reality is that in the surgery center, I mean, I know exactly who everyone is going to be. I know exactly who every member of the team is. Whereas in the hospital, there is a lot more unpredictability, and I think it's just unavoidable. I think we all kind of experience that because it's just a much bigger system. There's much more many more people, and there's many more like spaces that they have to fill. So I actually think that the best case scenario of working with a team where you know them, they know you, I think it happens much more in an ASC.
Yeah. It's still on the topic of anesthesia. We talked about this before. There's a particular type of spine surgery that I do, minimally invasive, which is endoscopic spine surgery,
Yeah.
where I prefer doing this with a patient awake with some light sedation, enough sedation to where it takes away their anxiety, takes away their pain to a certain extent, and also their memory. So they don't remember any anything during the case,
Yeah.
or sporadically. But it's still, the main thing is the anxiety level is very low. And this particular surgery, like uh, Dr. Radcliffe does some surgeries like this also. I go to some of the conferences, and the big discussion is, should you do these under general anesthesia or do it under local with sedation? By far, the vote is always toward sedation and not general anesthesia, like intubation, paralysis, put them on a ventilator kind of thing. That's general anesthesia. And I used to argue that till I turned blue, but there's a couple of guys that come up with some good arguments on why you need to put these people under general anesthesia, intubate them, and paralyze them, put them on a ventilator. And it's what we talked about as far as the care of the care of the patient in the hospital compared to in the surgery center. In the hospital, for example, a university setting where you have residents, you have attending physicians, you have nurse anesthetists, and they're all work. Like I said, you could do an hour case, 2 hour case, and have 4 or 5 different people coming in there, doctors or doctor extenders, to actually do the anesthesia on somebody. You cannot efficiently and safely do anesthesia on a patient with sedation, the way we like to do it, with more than one anesthesiologist. It's because the continuity of care is not there. So this guy's argument said, listen, I don't have a surgery center. I can only do it in the hospital. And in the hospital, we get 5 or 6 different anesthesiologists during one case. And I said to him, I said, you know what? You're right. Put him under general anesthesia because it becomes more dangerous. Because like Dr. Radcliffe, it's less labor intensive to just go in there, induce the patient, put him to sleep, intubate him, paralyze him, intubate him, put him on a ventilator, and just put the settings up. Everything's on autopilot. It's a cruise control. And you usually have the gases, which most surgeons don't like the gas effect. And you could talk about that. Whereas we do total intravenous anesthesia, which is much better. And they get the gases, they nitrous oxide and some kind of vapor gas that goes into the lungs. It keeps them asleep, and occasionally you give them some IV stuff. But it's really a cruise control, and you have the anesthesia machine, which is set up with all kinds of alarms. Like on my car, if I go over 150 miles an hour, alarm goes off.
Right.
But telling me I better slow down because sometimes it gets away from me. You know what I mean? But how does the general population feel about TiVo anesthesia, total intravenous anesthesia, or TIVA, compared to gas? The general population of spine surgeons. I think you mentioned that one time.
Yeah, absolutely. So there's different ways to do anesthesia, as Dr. Jasper alluded to. And just to be clear, when he says paralyze, he means that you give a medicine that keeps the muscles from contracting, and so then it makes people move less during the surgery. It's not like a paralysis, like like Christopher Reeve or somebody. Meaning that it's just a medical thing. But anyway, that's the traditional way that anesthesia is done. It's the way that, if you were going to get a appendectomy or something, you would do it. And it's different from the way that we do anesthesia when we're doing procedures on or around the nerves. What Dr. Jasper alluded to, where he said intravenous anesthesia or TIVA, there's this medicine that's given that's actually much more expensive, from what I understand. And it has to be kind of carefully watched and balanced. But the benefit is tremendous that you don't get that same nausea and vomiting after that type of anesthesia compared to if you just get a gas where they say, all right, count to 10. And so that's a tremendous advantage. And then also it allows for more careful nerve testing. The gas kind of interferes with some of the nerve testing that we do during surgery. So depending on the type of surgery that's being done, I prefer the TIVA, the IV anesthesia in most of my cases. I think the benefits are really there. And I mean, we're not trying to disparage the hospitals. It's just that, Dr. Jasper's right. In the hospital, there's just so many more people involved, and there's so much more variability. If someone gets a little too much anesthesia, they take a little too long to wake up, they just put them in the recovery room longer. And if they're there for an hour, hour and a half, 2 hours, you can do that. In our center, it's much more streamlined and efficient. And so, Dr. Jasper knows, like, look, I mean, he can go into the recovery room. It's 20 feet away and see, oh, you know what, let me lighten this person up a little bit. I gave him too much anesthesia, or I didn't give him enough. Let me give him a little more. And just by having that continuity in the same person, giving the anesthesia, watching them after surgery. And in many cases, Dr. Jasper's treated them before for injections, stuff like that. It really adds a lot of, I think, individualized care to the just to the experience. And I think people get a much better experience that way.
Yeah, I mean, you not only know in a surgery center, you not only know the staff, very, very closely, and the personalities and how good they are, and the strong points and weak points, and how to work around it, which is very little weak points in our place. But
Right.
but also the fact that the patients, they're there, and they come more than once, and we
Yeah.
know all the patients by first name.
Oh
It's
yeah.
not like in a hospital, you're a number, really. Nobody knows you in our surgery center, because people come when it comes to pain, spine pain especially.
I mean, I do the marketing. I walk through the hallway, and they recognize me and
Yeah.
call me over. If that's strange.
Well, it's because you're all over the TV.
No, but I mean,
American Most
yeah,
Wanted.
true, but still,
So I mean that the patients, and for example, in our setting, we work closely together because quite frankly, I've always said this, that spine surgeons should always learn how to do epidurals,
Yeah.
and how to do selective nerve root blocks. Of course, Dr. Radcliffe has me. I can do it, so he doesn't have to. But it's always a good idea, especially if you're a surgeon on your own, or even working with a group that doesn't have pain doctors or injectionists, as they can call them. Whereas if you're not sure if you have to operate on one level or the other level, you do a selective nerve root block at the level that you think is the worst level based on their symptoms. And if they get close to 100% pain free by blocking that nerve, let's say this nerve here is getting pinched. Oh, you got to put me on there.
yeah,
Let's say this nerve here is getting pinched, but the other one above it and below it looks like they're getting pinched. But you can narrow it down by blocking the nerve with a numbing medication. And if they're 80 to 100% pain free, then that's the level you got to operate on. And then Dr. Radcliffe knows which level he's got to operate on. Now, if you're 50% pain free here, and you go to the other level and you're 50% pain free, then that both of those levels need to be operated on.
right.
Yeah.
So we know these patients because we've, as far as anesthesia goes, we've done the anesthesia for certain injections. Now we got to do the surgery. So we know what kind of patient, how they respond. Do we know what doses we have to give them? So we give them the minimum dose to get the maximum effect. If you don't know the patient, you got to, if you're a good anesthesiologist, it's no big deal because you titrate to effect. But that's another benefit by knowing the patients and doing some diagnostic procedures. And by the way, if somebody has a pinched nerve and sciatica pain, and probably 80% of people do an epidural on them, and they don't need surgery.
Yeah.
So that's a good benefit too.
Hey, are you seeing more challenges with prior authorization and insurance companies?
Oh, don't get me going on that.
Tell me a little bit about your experience with that, because I'm seeing that also.
Well, it's the Medicare disadvantage.
Disadvantage.
You get me on that now. Forget. Patients are waiting longer in my office now because of this reason. I got at least 65 patients that need a particular procedure that is a great procedure, and it's proved many, many times in my practice and other practices that it works beautifully, and Medicare pays for it. And it's an intraspinal spacer, which is used for spinal stenosis. People who can't sit down, because when they could sit down, they sit down, the spine opens up, they stand up, it collapses. You put a spacer in it, and it doesn't collapse, and the patients do well walking. There's a lot more detail behind that, but the point is, Medicare Advantage programs do not pay for that. And now there's more and more procedures that they don't pay for, where at the same time, they promise when you get it that they're going to pay for whatever Medicare pays for, which is not true. I had a patient that came in about a month ago with a fracture of the spine and compression fracture. She sat there and she was crying with her family members saying, "I want to die. I'm in so much pain. I can't walk. I can't breathe. If I cough, it hurts. If I sneeze, it hurts. Forget about laughing. I haven't laughed in 2 weeks, 3 weeks, whatever it was."
This is what people used to say. Oh, he's got a broken back.
Well, broken back, it's called a compression fracture.
Right.
And they're one of the most painful things you could have. And I fix it in a very short period of time.
Yeah.
A very short period of time. And they walk out of it. 98% of people walk out of the recovery room with zero pain.
Yeah.
So you come in with a pain score of 10 out of 10, you leave with a 0 out of 10 pain. But we put in for, she had Medicare, Aetna Medicare disadvantage, I call it. It's Medicare Advantage. And it's Aetna's the primary. So now, because Aetna is the primary, we have no longer the doctors and the patients no longer have a choice of what they can do. They have complete control of what could be done, what cannot be done. This lady had severe pain. They denied it like 3 or 4 times. Finally, I wrote a letter. I don't know if it was a letter, but I wrote the letter that the patient is unable to breathe. She's unable to cough. She's unable to sneeze. I said, she's at a high risk now of developing pneumonia and atelectasis. I said, patient can't walk because she's in severe pain. And so that puts her at a high risk for deep vein thrombosis, right? Which can eventually break off and cause a pulmonary embolism and death. And I went on with this. And I said, and after the third denial of this patient in severe pain, I said, if any of the above complications occur, I, as a physician, will commit to being an expert witness to sue the insurance company if this patient has a bad consequence.
Oh, yeah.
Then they approved it. I don't know if it was because of that or because, because they really don't give a shit, what you say.
Right.
Who gets on the phone with you when you do these appeals and peer-to-peer? You're a spine specialist, so I assume they have another spine specialist like you talk shop and say, hey, does this person really need to get the fracture fixed, right? They have somebody who knows what you're talking about,
It's the
right?
same guy that also does the calls for like fixing an old VCR.
No, that's a good point.
Who gets on the phone with you though?
That's
somebody knows what they're doing, right?
Well, that's a great point you bring up because when it was just Medicare with a secondary, when it had the traditional insurance companies like Aetna, United Healthcare, Blue Cross Blue Shield, all of these companies, they had a process where you had to get the approvals. Not all of them, depends what you get, what you pay for. But some of them you have to get it pre-approved. And they give us a hard time. We'd have to appeal it. And the first thing I would order would be a peer-to-peer, they call it.
Yeah.
So a peer-to-peer, and they would have a doctor, not always a doctor that does what you do. Sometimes it'd be a retired 92-year-old OBGYN doctor. Well, that was a worst part of the scenario.
Yeah.
In the old days, it was the worst part. So you get the wrong doctor. You say, listen, doc, I respect everything you've done in your life and your career, but you don't mind if I ask for somebody who knows about what I want to discuss and rationalize why we got to do the procedures. Yeah, no problem, doc. Then they send somebody. So that was the worst scenario in the old days. But now you get an orthopedic neurospine surgeon or an interventional pain doc that knows everything about what we do. And you got Aetna or United Healthcare or Braven disadvantaged programs. And I demand to talk to the peer review doctor, and they call you up and say, hey, doc, how you doing? I said, all right. I said, what kind of doctor is that? I'm an orthopedic surgeon. I said, great. So you know what we're going to talk about? Yeah. I said, you review the patient? He goes, no. All right. Well, I'm going to review it. I'm going to present it to you. And I present the patient to them, and they're like, you know what? I see here what you want to do, and I agree 100%. But if I had the authorization to say, okay, you can do it, and it'll be authorized, I would say authorize it.
Yeah.
However, I don't. But I will quote to you what I have in front of me.
Yeah.
Aetna Advantage programs do not cover this procedure. I said, are you kidding me?
Yeah.
So we've been on the phone for 10, 15 minutes, and I got an office full of patients, and this is what you got to tell me?
Yeah.
Then why did we even talk to each other? He goes, I agree. I said, well, you got a nice job over there. I said, maybe one day I'll get a job like yours.
You would go crazy.
I'm a little
Dr.
bit.
J.
Listen, some of the stuff that I say to these guys, I can't even say on the air. I guess it's a podcast. You can say whatever
Yeah,
you want.
you can say whatever you want.
But it's not very nice.
Yeah.
Sometimes you should be ashamed of yourself.
Really?
Get a real job, like go wash cars or something.
That's why we don't put the camera on me. I'm all belligerent.
So I agree. And I think it's really important to talk about this. People trust their insurance companies. If you ask people, they say, oh, I don't like insurance companies, but my company's good. And what they don't always realize is that the insurance company makes these rules that don't kind of have a lot of basis in fact or medical literature. That doesn't comply with what we, as doctors think. And then, the rules can ultimately deny necessary procedures and care. And yeah, I've been in the same situation where, a reviewing doctor's like, Aetna decided at one point that you couldn't get an MRI unless you have some sort of weakness or something. And I had this reviewing doctor get on the phone with me and say, look, I get it. Your patient has a lot of pain. They have numbness, but not weakness. He said, I'm just telling you, the only way you're going to get this approved is if you just change your notes and document that they have some kind of weakness. It's the only way you're going to get an MRI done. And, you know, it's sad that like these corporations that are, by the way, billion-dollar corporations, lots of profit, get to make these arbitrary rules. They have a lot of protection under the law for how they do it, and we don't really have a lot of recourse. And so, you know, I think it's important that people realize that these insurance companies are for-profit companies. They're not out to help the patients, and that, you know, they make money by not spending money on you as a patient. And we're fighting them, but we have very limited resources.
You know, now we're on the subject of this. There's they don't even tell you. They tell you that I think December 31st is the last time. That's the period open enrollment changing. It isn't. It's up until March 31st. So you have some time now. And people who are having problems, or if you anticipate a problem, which, you know, we're not getting any younger. Everybody's going to have a problem sooner or later. If it's a light problem, nothing, you know, generic thing that goes wrong with you, chances are they're going to pay for it without a problem. But now there's expensive things that need to be done, and these are the things that they don't want to pay for. So, so if you have a Medicare Advantage program, what you need to do is you need to change to a Medicare strict, traditional Medicare, red, white, and blue card. I mean, you just call up, I think it's 1-800-Medicare, right? And you talk to them, you know, and you know, I sound like a sales guy over here because I get so aggravated now. I get anxiety thinking about it. That these poor patients are not being treated, they're not being treated right. And I mean, I've heard stories. I don't know if I brought it on the line, but Michelle was telling me that, and I think I might have told you, there was a family that a mother got cancer. You know, I think it was breast cancer, and it got so out of hand that they couldn't cure her, put her in remission. She ended up going into hospice, and it was a family, and she went into hospice, and she had, you know, obviously, you know, she was old enough to where, you know, she had a Medicare Advantage program, and when she went into hospice, and they figured she's only going to die in a couple months. But she ended up dying like, you know, a few months extra, like maybe 3 to 6 months. Right. And what happened was the Medicare Advantage program decided on their own that we're only obligated to pay for 2 or 3 months, whatever it was. And the last couple of months, the family had to pay for it. They had to sell a house. They They owed $165,000. And you got some people that are very, very, like me, I'm very aware of not wanting to ruin my credit. Right. So they ended up paying the bill because it's a hospital bill, hospice bill, medication, radiation, whatever there was, $165,000 that they had to pay. And they basically went bankrupt. That's their fortune. That's their nest egg gone. And another thing is, people don't realize that Medicare, if you have Medicare and you get a devastating disease, Medicare will pay for it. It's the state, it's a government. They're obligated to pay for it. Now, of course, you have to have a secondary, and you have a secondary. If Medicare pays for it, the secondary is obligated to pay for it, even if it is Aetna. But when they're primary, they do whatever the hell they want, and you don't know what they're going to do. So if you got a devastating disease, now they refuse to pay for certain things. They'll say, no, you can't have this kind of chemotherapy, but we'll give you this kind, and this kind doesn't work as good as that kind. Right. You know, they got this different criteria.
We'll help you live, but only for a little bit.
Yeah. So what happens? Patients say, all right, the hell with it. I'm going back to Medicare. You don't know about this when you go to Medicare Advantage. I'm going back to Medicare. So Medicare will give them their insurance, but that's only 80% of whatever you got to pay. Yeah. Whatever's billed is 80%. You got to get a secondary that pays the other 20%, which could be an astronomical amount of money, 20%, you know, the way medicine costs today. And you got to get a company that will accept you. And now you got a devastating disease. You know what they say? Listen, you got pre-existing disease. We're not going to insure you. So now you're screwed. Yeah. You're up Schitt's Creek without a paddle.
Right when you need them the most.
So these little things that you don't understand. And let me tell you, right now, anybody listening, you need to go on YouTube videos. If you can't do it, get somebody to do it for you. And you type in the advantages and disadvantages of Medicare Advantage programs. And after you educate yourself. I mean, I'm not making this stuff up. You educate yourself. And also what you need to do is look for, just type in class action to Medicare Advantage programs. They're popping up all over the place, which is a good thing because that means that it's going to go away.
Yeah.
Which is a good thing. Can't wait for it to go away. It's getting worse and worse, like you said. It's getting harder and harder to get certain things. Every week that goes by, something that was approved. In fact, these procedures with the Minuteman by Spinal Simplicity, they were paying for it. A year and a half ago, they stopped paying for it.
Right.
And now I got 65 people who, by the way, if you're going to go back to Medicare with back pain, right, little spinal stenosis, you can get a secondary. That's not a pre-existing disease. It's something acceptable. So people need to understand that if they got spinal stenosis and they need to get a procedure, they're not going to pay for it, just get Medicare.
Yeah, I'm in a very similar situation. I like doing artificial disc replacements instead of fusions. And there's good data. I've done a bunch of research on it and stuff, and I've done disc replacements myself. Up until like March of 2023, I believe, Aetna just decided they wouldn't cover lumbar disc replacements at all. I mean, they've been on the market for over a decade. All the other insurance companies cover it, and it just didn't cover it. There was a class action lawsuit at which Aetna lost, and then they rewrote their policy and said, "Fine, we'll cover lumbar disc replacement." So I had a lady who was a school principal, was a good candidate, and I thought would really benefit from a disc replacement. And it was denied. And I got on the phone with this doctor, very nice doctor. I believe she was in San Antonio. And she said, well, it was denied because the person had a previous like discectomy, like a long time before. And Aetna's policy said, if you've had any previous procedures, endoscopic discectomy, lumbar microdiscectomy, anything, you can't get a disc replacement. And I said, well, show me that in the literature. Show me what the basis for that is. She said, can't tell you. I pulled the papers, and 30-40% of people who had disc replacement in these FDA studies had a previous surgery, and they did fine. And so, again, the insurance companies can just make up rules however they want.
That's what it is.
And you really have no recourse as a doc or even as a patient to sort of fight that. It's really a challenge. There's this other thing now called TOPS, which is for spinal stenosis patients, and it's a way that you can remove these things called the facet joints, but instead of fusing like you normally would, it maintains movement. It can still move, and so then the risk of other problems at other levels is minimized. The idea that if you fuse one area, maybe you transfer some stress and make the other areas wear out too quickly, that's removed. The private insurance companies, including Aetna, Cigna, they just don't cover it. Medicare will cover it, but if you have one of those disadvantage plans like Dr. Jasper is alluding to, you can't get it. So it's really disturbing the way that insurance companies that are kind of faceless and nameless and that they kind of dictate what happens to real people and real healthcare, and there's no accountability for it. It's not like anybody at the insurance company ever has to sort of say, hey, well, sorry, we don't think this is a good idea for you. It's really a challenge.
We're like that guy. What's the guy that just got killed in Russia?
Navalny.
Yeah, we're like him, but we're from, we're talking about the insurance company.
Yeah.
And we're rebelling against it. We will overcome. He was never going to overcome, but we will overcome because of people like us, the patients are listening. When the patient's listening and they start to act, now you got your own army.
Yeah.
And the patients really need. I got some patients that we've had Medicare, we have Aetna Medicare. We've appealed it with patients' help, and we're able to appeal it.
Yeah.
And win. So the patients got to contribute to the fight.
Yeah.
Get these treatments done. And any patients out there that have been denied anything should look up class actions for the same thing that you have been denied for and join it. You know,
The other resource is the Division of Banking and Insurance in New Jersey. It's called Dobie, and they're a good resource if patients go on there and complain and protest, because it really is unethical. These people pay their premiums. They think they're getting a certain a level of care. You can pick your own doctor and so forth, and fine, you can pick your doctor, but your doctor can't pick the treatment that you need. It's almost like a false advertising thing. So yeah, it's really a challenge.
yeah, talking about before, I was talking about this via disc where they process the nucleus, healthy nucleus, and they put in powder form, they reconstitute, and you put it in. I mean that's they've had many studies that it's been working. It's been working well, and it's a very basic procedure. It takes very short period of time to do. Low pain. The patient can have it done like an epidural, for God's sakes, and the success rates are supposed to be pretty high. Of course, if you need surgery, disc replacement, you need it. I'm the first one to say, but these are the people that are much earlier in their disease process that
Yep.
you can actually stop it and slow it down. This is what they're predicting. But guess what? Like you said, Medicare will pay for it. The Medicare Advantage programs won't pay for it, and the traditional insurance won't pay for it. And what's bad about that is you need to get these patients when they begin to have degenerative disc disease, where they're not candidates for surgery. And you can see, and that's the goal, is to see how you can slow down the degenerative process. And they have proved statistically in studies that made it statistically significant to where it decreases, it slows down the process of degenerative disc disease. And we're allowed to do it in people who's probably too far gone. The degenerative disc disease on some of these people too far gone. The earlier you get it, probably the better it is. But the people who need it the most, we can't do it because of the insurance companies. We're beating
Yeah.
a dead dog here.
I agree. I think on that note, the degenerative disc disease, people kind of uh, it's not always clear what causes that or when it really starts, and it's really important. Something Dr. Jasper said just a moment ago. What happens is we have these cells that sort of make these molecules that are a type of cartilage called proteoglycan, and those molecules are sponges and they suck in water. And so our discs have a lot of water in them, and that's the cushioning. But the water's there because these cells make these certain molecules. And over time, the cells get, sort of fatigued and older. Some of them die, and then you don't get the same molecules, and so then the discs dry up. So you can't just inject water in the disc because it'll evaporate or wash away. But if you put in new cells, which is what the Via Disc is, there's other companies too. Discgenics has a trial going on now. Then they can maybe make some new molecules, pull in some water, and help to keep the discs hydrated. And like Dr. Jasper said, it's something that is probably perfect for a mild to moderate and intermediate level problem. If you got bone on bone and you're in bad shape, you got a drop foot like Jeremy had, you're not going to benefit from a cell injection at that time. You need a little more invasive of a treatment. But if you can get to it early, there is a role for it. And I really think it's unfortunate that the insurance companies aren't willing to support that. I think the reason why is because people change insurance companies every 2 years. So the reality is, from their perspective, if United Healthcare spends money for you to get stem cells injected in your disc, by the time, like, whatever they would have prevented, you're likely not to be on United Healthcare's dime anyway. And conversely, Medicare, which has people for life, and I believe that the TRICARE also, for life, they are more willing to look at those preventative measures. But I think that's what we're going to see. It's going to be like they call it visco supplementation or rooster combs in knees and so forth, that by putting in those kind of cartilage molecules early, you can help to either prevent or delay the need for more invasive stuff down the road.
I've had patients 3 generations sitting in my office, and they bring the mother in because she's got severe degenerative disc disease with severe central canal stenosis. my father was 95 years old. He had no central canal stenosis. And this lady was about 75, 78 years old with central canal stenosis. And her daughter, that's like, 50, 60 years old,
Mhm.
says, I got the same problem. I can't walk that far. Without even doing an MRI on her, I bet you she already has central canal stenosis.
Sure.
And then now you got her daughter sitting there saying, I've been having back pain for about 4 years now. So it is definitely a genetic factor. And I remember going to a conference in France. It was a world conference of minimally invasive spine surgery. And one of the guys presented a study that they did, and he was quoting other studies where they found a genotype. In other words, somebody young compared to the parents that had the same genotype that was correlated to the genetic constitution of these patients, that they will get degenerative disc disease and most likely spinal stenosis. So I already know what's causing it. I know the gene that's missing for that, according to this guy's presentation. I haven't, I don't even have time to do that kind of research, but it's very interesting. And they were saying that we don't know how we're going to do it, but the future is not now because it's too late for all of us. The future is that the people are being born now and to be able to prevent them from getting degenerative disc disease. Of course, it put us all out of business, but and that's probably one of the reasons why they haven't come out with it yet.
Right.
But now the question that he said, how do we administer this genotype, this part of a gene, this gene that's missing, which is basically proteins, like you say, what'd you call them before?
Proteoglycan.
Yeah, I mean, maybe something that produces these cells that do their work, and it's an enzyme. It could be a chemical reaction that's missing that these people are lacking, causes the problem. How do you administer it? They were talking maybe inject it directly into the disc.
Yep.
Or maybe intravenously, but that was the last I heard of it. I don't think anybody's. I'm sure there's people out there working on it. We should find out.
Yeah.
But who knows? But that's great. What a great topic today. We, it's not a pretty topic. It's reality,
Right.
which medicine goes through different phases, different waves, and right now we're going through a phase now where these insurance companies are going to get knocked right out of the water. With due time, patients are starting to get fed up. They're going to go away.
You're also seeing a lot of the doctor societies also kind of organizing, and there's pressure for what's called prior authorization reform to make it more straightforward and simple. I mean, I do think you're right that there's going to be some movement on that. I just think it's important that patients understand that, you would think that we would be the ones to be able to make the call within reason, especially for testing and for, kind of, I mean, we're hearing the patient's story, but unfortunately, sometimes you just can't.
I mean, sometimes it's so ridiculous that what they deny. Patient comes to your office with back pain, with sciatica pain, ridiculous pain, all the way down to their foot, maybe even a foot drop or something. But even if they don't have a foot drop, but they got a clear clinical sign, symptoms of something that needs to be discovered or reviewed with an MRI, and they deny the MRI. Like, who's making these decisions? Well, you need an X-ray first.
No. There's a study on this. It was in ProPublica, where they got, I think it was either United Healthcare or Cigna, and they looked at. I mean, they have like an AI algorithm that reviews all the paperwork and just kind of pulls out factors. And so I forget what the statistic was, but something like the reviewing doctors for this one insurance company spent an average of like 4 or 5 seconds per chart, because the chart gets pulled up, the computer says, all right, this is why you're going to deny it, this, and they say, okay, submit, and that's it. And so no, that's exactly it. So
this is a great topic, but let's talk about, as a conclusion of our show today, what's new in orthopedic spine surgeons for patients today that people, or relatively new, that you do that would help patients, and they would understand maybe what kind of symptoms they have, would understand on how you could help them.
Sure. Yeah, so I think that artificial disc replacement is really growing and taking off and exciting. As I said, I've done a bunch of research on it, and I have some experience, some clinical experience, and I've been really excited by the outcome. We're now on kind of like a third generation implant. So the first disc replacements came out in like the late 2000s, and then some other ones came out in 2010s, and now we have really sophisticated designs, good surfaces, and we understand the sizing much better. When you get a hip or knee replacement, it's critical that it be sized appropriately, and that's really critical to having it move properly, not dislocate, not become unstable, and other stuff. Now we have much better range of sizes and options. So what I think is that we're going to start seeing a move, hopefully, from fusion towards disc replacement. And like in my mind, I kind of look at it through the lens of every person is a candidate for a disc replacement until I kind of prove otherwise. Now, sometimes it's obvious, if you have a fracture, if you have bad osteoporosis, there's reasons that you can't get an artificial disc replacement. But but at least it's becoming a much more standard mainstream option. And again, unfortunately, the only real challenge, one of the big challenges, is that you can't do it at three levels because the insurance companies won't approve it for three levels.
How
So
many
that
levels? One or two?
two, they'll go up to two. So that's a bit of a fight, but that it's really nice, especially for cervical problems. People bounce back quickly. It's not as bulky as a fusion, so maybe the trouble swallowing and the voice problems are minimized. It's good in that regard. The other thing that's interesting, and I haven't really picked your brain about this, but um, there's a new test to tell where, like sort of the source of back pain. It's called MRI spectroscopy, or NOCI scan, NOCISCAN, and it's kind of intended to sort of look at
That was a
as a
mouthful. That
as a
was
successor
good.
to discography. So, Dr.
Wow.
J, can you talk about discography a little bit? Like, what are your thoughts on it? What's the accuracy of it? How does it fit into your practice?
Discography, what it actually is you stick a needle inside the disc, and you make sure you stick it right into the center of the disc. And in theory, that if you increase the pressure to a certain amount, and if it's a low pressure and the patient experiences while they're awake on the table, they experience pain, a lot of pressure, and it's got to be concordant pain, the kind of pain that they normally have. That would be a positive disc. And if the patient has, let's say, degenerative disc disease at 4 levels, you'd have to do 5 levels discography, and it's got to be in a way that the patient doesn't know what level you're in,
Yeah.
and you have to. This makes it more accurate and more believable because you have patients that might be malingering. You don't know, but what you do is you increase the pressure. Let's say on the first one that you think is bad, and you describe the pain and the pressure at what the pain started, where they started to experience the pain, and it's concordant. And then you go to the next level. Then you slip in there the good level, right? You got to make sure that the pain has dissipated from the previous level before you actually inject it. And you inject a good level, and technically they're supposed to say, "Oh, I just feel a little pressure. I don't feel any pain." The accuracy of that it's subjective.
Yeah.
Right? It's subjective based on the patient. They have anxiety. You're sticking needles in their back, so they're ramped up as far as the sensitivity of pain. So I think that one of the reasons why they stopped actually paying for this procedure is because you couldn't get a real accurate results of it. It was something that you put into your toolbox as far as a diagnostic tool to figure out what levels you were going to operate on.
Yep.
It wasn't the this is it, positive. These are the ones we operate on. It's one of the tools in the tool shed as far as diagnostic tool, and then you put it all together, you make a decision. But unfortunately, you can't use that tool anymore because it's not being paid for. I use discography when I do certain procedures, like when I do minimally invasive surgery. I'll do a discography because what it shows me, if you get a good view on AP lateral, maybe a contralateral oblique, and you see if it leaks out. And where it leaks out, you can see that there's a hole in the disc, and you can do an annuloplasty intraoperatively and just seal it up to a certain extent. Does it work? Probably not 100%. And they have stuff now you can actually seal it up with. But I'm not. I wasn't real keen on
Yeah.
it, and it's kind of gone to the wayside now.
Yeah, so that's how I feel also. I'll say this is something we said earlier, but for me in particular, discography has got to be done by somebody I know and trust, because it's so. My advice for patients is, if someone says go get a discogram, you should ask, like, who do you know, who do you trust to do it, because it is, there's a lot of subjectivity in it. You're putting needles in the back. You're asking the person while they have needles in their back, hey, does this feel like your normal pain or not? And it just it's really hard to kind of translate that in the chart.
Too many variables.
A lot of variables, and especially if you have, like, let's say, just different people doing it, different bedside manner, different, so to me, I want my discograms done by one person who I know, who's got a lot of experience with it, and there's value in it. So that's where this other test comes up. It's a special type of MRI. It's done actually by one of the RadNet facilities, the NGIN facility, but it's up in North Jersey. But it's a special type of MRI that measures certain molecules in the disc, and they have data that those molecules, and I'm talking about like lactic acid and some other molecules, those molecules correlate to pain. So I, I think that's really exciting to be able to have a molecular marker to say, yeah, this disc has a bunch of lactate molecules or sodium molecules or whatever, and we believe this is where the pain is coming from. I think it'll enable us to target our interventions much more precisely, and to kind of have a little more precision with the planning of our procedures. I think that's really exciting. Endoscopic surgery certainly is a topic of growing interest in the spine community and the surgical community, and I think more and more people are doing it, and more people are looking at awake surgery and better pain control. And what can we do to help people bounce back quicker, and to not have that malaise after surgery that so many people suffer from.
Yeah, that's called using the right intravenous anesthetic and hydration. A lot of anesthesiologists don't realize that people who have the tendency to get nauseous after a procedure, and it's mostly based on the fact that they're dehydrated.
Yep.
You got a patient who's going to the operating room at 2 o'clock in the afternoon. They hadn't had anything to eat or drink since midnight, or not
Yep.
even. It's usually like 7 or 8 o'clock at night the night before. So you've gone hours and hours, and some of them like 250, 300 pounds. They are dehydrated. So as soon as you put any kind of anesthetic in the body, which decreases, no matter what it is, usually decreases the cardiac output. It causes a peripheral vasodilation, which means that if you don't have enough fluid in you, you're going to get a sudden decrease in blood pressure, which could not only cause you to have a heart attack and other things, but it's sort of your brain lacks oxygen and nutrients. The blood pressure goes down in the brain. And what it does is, at that point, and this is what we learned in residency, is that it stimulates the nausea center.
Yep.
As soon as, that's why people, when they get a vasovagal, they start vomiting. Some of them, they get nauseous.
Yep.
But if you hydrate the patient, and I'm very recover in the holding area, and they know I'm the anesthesiologist. They don't put in 500 cc bags; they'll put 1,000 cc bags. And depending on how big the person is, I want either that whole bag, and depending on what time of the day it is. If it's 7 o'clock in the morning, they don't need as much. But if it's 2, 3 o'clock in the afternoon, you give them that whole 1,000 cc.
Right.
Especially if the patient had a history of nausea and vomiting. And then guess what? Miraculously, the patients come up and said, "Doc, you're the first anesthesiologist that gave me anesthesia. I didn't get nauseous," because they were hydrated.
Yeah.
Everybody's in a rush. Nobody knows how much fluid they got. This is what happens, like we said, in the hospital.
I was talking to Phil about this, and it's an interesting area, is like that IV hydration. As a matter of fact, there's another friend of mine was telling me just this week, he's doing amino acid infusions before surgery to try to, because there's some data that, like in addition to just the fluid and the dehydration, getting more protein, amino acids are the building blocks for protein, kind of helps the body also to make sure that there's enough fuel for the brain to be able to work, and for the muscles to be able to work. And so I think that's another area that we're going to see evolve is just infusions, both for pain, and as well as to help people recover quicker.
I mean, you got so much stuff out there. And this is what's the beautiful thing about medicine and the evolution about medicine. The only problem is the insurance companies lag behind.
Yep.
And you want to get these good treatments, you got to pay out of pocket. But who's going to pay out of pocket? Very few people.
That's what my friend's doing. People pay out of pocket for it. He'll bring them in and give them an infusion of amino acids or something, and and it's worth it. It's worth it if you can get back to work a week early. It's worth it if you can get by without having to have your loved one take off work to help you move around the house or something. There's trade-offs, but sometimes it's a good investment to just invest in yourself for these things if needed.
All right, that was a good show. You got to come back more often.
Yeah, this is fun.
You know
This is
what?
good
I'm
times.
thinking if I do a lot of things. Lately I've been getting my instrument rating.
Yeah, you're
And
flying.
weekends I've concentrated. Today I'm here. I said, both of you said, "What about tomorrow? You want to go?" Well, it depends on the weather.
Yeah,
The weather's bad. We're on the show, but you're
we should do
welcome
this.
to come here, especially anytime you want.
Yeah,
Even if
man.
I'm here, if I'm not here, you talk
It's
to
fun.
Jeremy,
Yeah.
and you come in. You got a lot to talk about. You enjoy doing this, and I'm sure people enjoy listening to you.
Yeah, no, it's fun. It's fun though. It's
Yeah.
fun. It's fun. Kind of picking your brain.
Yeah,
And
anybody.
and it's
We
really fun.
we don't get. What's good about it? Sometimes we get a little technical, but we explain it in layman terms,
Right,
so people understand it.
Yeah. Well, I was like, as you were describing, some of the stuff with the Joe Piscopo, what was it?
I don't know, but you starting to sound like Joe Biden right now.
Joe
Oh.
You're starting to sound a little bit like Joe Biden right now. You better stop.
No, the
with that.
Medicare Advantage, but just it made me think, wow, you must be really starting to see some issues
Yeah,
with that
And
stuff.
I'd like to thank Jeremy.
absolutely.
How long you been working with us?
About 10 years.
10 years. Jeremy has been a fantastic contributor to the Jasper Spine Institute, and also with Dr. Radcliffe, he's helping him out too, as far as getting the word out there, being a diehard. He comes to work every time he's supposed to come to work. Even if he's not feeling well, he still comes to work, and he's doing a fantastic job. And I'd like to thank you very much, Jeremy.
Thank you, Doc.
Really, it's the audience can't see it, but I mean, it's a totally professional studio. It's awesome, and Jeremy's so good about just helping us sort of deal with the chat questions, putting the content out there. He's excited. It's the biggest compliment to Dr. Jasper. Like, I mean, a happy patient just sings your praises, and in this case, I mean, it's the best marriage. He's also a star with the media and marketing.
Yeah, patients see him all the time. Hey, you're the famous guy on the TV.
I get stopped all the time. All the time they stop me, and they're like,
I ask patients sometimes, how come who referred you here? That guy, the guy with the hat on your commercial. I'm here because of him. I got exactly what he has.
I usually have to have that on all the time, and then poof, it's that. Oh yeah.
That guy.
All right. Well, thank you very
That's
much, Dr. Radcliffe, Jeremy, and the audience. Anybody say anything? No. Listen, you can get in touch with us. Dr. Radcliffe, give me your number,
Yeah,
and your
absolutely.
location, and this way they can call you.
Yeah, sure. So 609-800-3472 is my number. Obviously, I have a website. You're welcome to look me up, and I have a couple locations. One in Brick, 74 Brick Boulevard. We're actually building out a whole office suite upstairs. We're just waiting on some permits. If anyone from Brick Township is listening, I'd appreciate if you could hurry that along. And
We're usually good at it.
we have an office down in Atlantic County and in Cherry Hill. But no, thank you so much for this opportunity.
That's great. And
I'd really like you to come back on.
Yeah, it's
I
fun.
mean, even
It's
if
fun.
it's just you
Absolutely.
and me,
Yeah, it's
we'll
fun.
hold the torch.
Yeah,
know.
and you can call my office at 732-262-0700. You can fax over your MRI at 732-262-0400. I'll go over it. Dr. Radcliffe will go over. We feel that we can help you. And this is free of charge. We're not going to charge you to review your MRI. But you could send that in if you live far away, because this goes all over the world now. And we have people coming in from all over the world to see us. And we take care of them. So hope to see you guys. And if you need anything, give us a call. Thank you.
Yeah, for more information about Dr. Gabriele Jasper and Dr. Chris Radcliffe, please go to jaspermd.com. We got a lot of exciting new stuff coming on our website. So